Hello and welcome to the latest in this series of NR Times roundtable discussions. My name's Alistair McCall. I'll be hosting the discussion today, and the subject that we're focusing on today is Brain Injury Rehab 2025 in Pursuit of Progress. And that coincides, of course, with Brain Injury Awareness Month. Today, very specifically, we'll be focusing down into the challenges and the opportunities that are going to shape brain injury care, both today and in the future. And I'm delighted to say we've got a fabulous panel with us today, experts from a wide range of disciplines who are prepared to share their experience with us and, of course, their insight as we talk about today and about the future. So we're going to start by asking each of our panelists just to say a few words about themselves, their organisations, and of course, their areas of very specific interest. If I could start with you, Martin, please.
Yeah, no problem at all. Thank you, Alistair. So I'm representing Neuro Case Management, who are proud to announce that we are either the one or one of the largest independent case management organisations in the country. I noticed through various research projects that over the past 5 years, a lot of case management companies have been acquired and purchased and are now not independent. But as a family-owned company, we're still offering what we perceive as value for money, and in terms of service provision, we try and go over and above both managing the person with the condition and their family, specialising in brain and spinal injured clients. So we're now 15 years on. We've sort of found our place now and found the level in the industry, and we're now looking forward to seeing the new changes coming through, and that's why I'm here today to talk about those.
Brilliant. That's a company with a real pedigree, Martin,
Yeah.
and some impressive achievements. Thank you. Keith, can I come to you next, please?
Sure, thanks, Alistair, and good morning, everybody. My name's Keith Jenkins. I'm a consultant clinical neuropsychologist, and I'm also the lead psychologist for the neuropsychiatry division here at St Andrews, Northampton, which those of you in the know within the brain injury field may know better as the Kemsley unit. So Kemsley was the first neurobehavioural rehabilitation unit for people with brain injury in the UK, and developed its skill set in the 1980s and has been growing and evolving ever since. So we have several wards catering for people who typically have been pushed out of other services because of the change in their behaviour and their ability to regulate their emotions after their brain injury. So we provide a service that can appropriately support, contain and rehabilitate people who for a period of time have lost that ability to manage themselves in social situations or in situations where they cannot get their needs met quickly or effectively. I've worked with people with brain injury ever since qualifying as a psychologist, which was back in 1991. I've been here at St Andrews since 2003. And I've also been involved with one of our local headways, that's Headway East Northamptonshire, where I'm currently proud to be the chair. And we run a day service for people living with brain injury in the community. So I've got this very fortunate awareness of some of the issues for people in the community and also issues within a specialist inpatient service. So I hope that some of that experience I've had will hopefully be able to be shared today.
Thanks, Keith, and we're looking forward to hearing more about that experience. Stephanie. I think you're still on mute, Stephanie.
You said you'd be the first, but I'm technology. I should not my forte. Morning, everyone. Yes, my name's Stephanie Clarke, and I'm a partner at Stewarts, which is the only firm that deals exclusively with catastrophic injury claims. Our caseloads are small cases. We deal with maybe 10 to 12 cases, and they're all claims that generally settle between 3 and 25 million. And my background is I've been qualified now for over 35 years, and I've worked exclusively with claimants and in the brain injury, spinal cord injury, and amputee and severe polytrauma. So I work in the London office as a partner, and I'm very aware of all the major trauma units and the rehab units. I've got a lot of exposure with similar units to Keith in terms of the Putney and the units around, the brain injury units around London. We're also very involved with Headway East London, which, as you say, the brain injury charities are invaluable, because of course I come from a background where generally I'm assisting people who've got personal injury claims, and hopefully my role is to access funds to give them rehabilitation. But as part of my role as well, I provide a free legal advice service to some of the rehab units around London. And there I'm dealing with people with stroke and brain injury who don't necessarily have any claim. And so, again, fully aware of what goes on, both compensation and non-compensation. And, we see what happens with NHS England this morning. We've just heard that that's going to be abolished. Of course, for people who've had severe brain injuries, NHS England is the organisation that provides the rehabilitation prescriptions. So, really enjoyed working in this field, and hopefully feel we make a difference, but there's a hell of a long way to go in terms of provision for brain injured people.
Thanks very much, Stephanie, and we'll probe into some of those challenges and opportunities next. We've also got Charlotte Robinson with us today from Alcedo Care, but Charlotte's having a few technical issues, so I'm hoping that when Charlotte joins us, Charlotte will be able to introduce herself, but more of that later, we hope. Martin, can I come to you first? Our subject today is the challenges and opportunities really shaping brain injury care both today and in the future. I mean, it's a very topical time, as Stephanie said, given some of the changes to NHS England, but can you maybe give us your views and thoughts on challenges and opportunities to kick off the discussion today?
Absolutely, no problem, Alistair. So when we originally launched in 2010, I think it was pretty much in the beginning of the industry almost, whereby a lot of referrals were getting mixed up, and people didn't really know how to make the referrals or how to pick up the necessary documentation and work with those. So the past 10 years really has been quite a developmental period really in the industry. However, because of the industry being unregulated, we've certainly noticed in the past 7 or 8 years, especially before COVID and during COVID, that there has been a lot of organisations set up offering ridiculous prices and what they can and can't do. So I am absolutely over the moon to note and to state that as of last year, possibly the year before, through CMS UK, Case Management UK, the industry is now becoming regulated. So the IRCM, the Institute of Regulated Case Management, is actually now in force, and any case management firm worth the salt who has had at least 5,000 hours experience can now join the IRCM. And I'm now very, very pleased to announce that as the industry is regulated, it should weed out the people just actually coming into the industry for not the correct reasons and just to pursue their own financial gains, which my background is social worker. I'm a senior brain injury social worker and have been for 23 years. So a lot of my experience has been cobbling together packages of care for not much money within social services. Moving into the private sector has allowed me to work on a greater depth with the clients who have got fortunate enough to have a claim, and we can then try and make them as independent as possible in the community for the rest of their life. So my my happy place is to note that we are, as an industry, case management industry, becoming regulated. The only other box to tick is for all case managers who are then regulated is to become CQC registered, and then they can claim clinical governance on top of everything else. Okay.
Great, thanks very much, Martin.
Okay.
I'm delighted that Charlotte's joined us, and you've dealt with your technical issues, Charlotte. We're just talking about the challenges and opportunities shaping brain injury care. I'm going to go to Keith and Stephanie to talk about that subject, and then I'll ask you, Charlotte, maybe to say a few words about yourself, your organisation, and then do the same, talk about challenges and opportunities. But I'll come to Keith next. Keith, challenges and opportunities for brain injury care today?
I think probably people working in the field won't be at all surprised to hear. I'd probably describe the major ongoing challenge being funding, so the availability of funds to provide the right length of time in service and the right quality of service. And then the next major issue that's semi-associated with that are the issues of coordination. We experience that particularly as an inpatient service. So it may be that initially our patients are funded by the integrated care systems for their particular area of origin. But then when it comes to working on discharging them, often we need then to look to colleagues in social care. And there can be significant delays and challenges in getting social care on board. And even when you find a suitable placement that can start building a life outside of hospital for someone who's living with a severe brain injury, you'll find that it can take a long time to get funding approval. And I guess the final bit of the challenge is that for decades now, we've heard about the postcode lottery with reference to the NHS. And certainly it's still absolutely the case that for people living with brain injury, it is a postcode lottery. It depends where they live, what's going to be available in terms of services and also support from the voluntary sector, because organisations like Headway are not everywhere. And each Headway service varies depending upon the people that have pulled that service together and the availability of funding in the local area. In terms of an opportunity, well, there is a ball that was dropped because of the general election that we had last year. That ball was the ABI bill and the replacement for the ABI bill that was put in place, which was a working group that was meant to be stretched across all relevant government departments to coordinate the offer and the services for people with brain injury. Now, it's, as I say, it's a dropped ball at the moment because when the general election came along, surprise, surprise, that work was halted. So we've heard noises off since about maybe getting that group together and making the progress that was promised at the time. But that's really an opportunity. We as people working in brain injury and working through organisations like the United Kingdom Acquired Brain Injury Forum and Headway, we need to try and pressurise the government to make sure that people with brain injury and their needs are recognised and recognised coherently across all relevant departments. And that might be health and social care, but also the Ministry of Justice in terms of the number of people with brain injury in prison, and the education system, the way in which young people who have had brain injuries can still be failed by the system. So there's a potential there for hope for the future, but it needs a bit of work.
Thanks very much, Keith. A lot there to unpick during the course of the discussion. At some point in the future, it would be interesting to hear from Chris Bryant about where the ABI bill and the key parts of it are going over the course of the next year or two. Stephanie, can I come to you next? You
can, Alistair. And Alistair, I'm going to be asking you to shake it all up and move us all around, because I'm going to be ended up saying that I concur with my learned friends here, because the points I had were exactly the same as Keith. Funding, quality of care, the longevity of that care, and the real difficulty is when you have the continuing healthcare funding and trying to get direct payments, And particularly working in London and around London, we know there's a huge difference between the south of London and the east of London as to what will be awarded in terms of direct payments or care for people with brain injuries. And of course, we've also seen that, when we come to looking at personal independence payments, that's going to be another area that will be, is going to be scrutinised and quite rightly across the board. But we have to remember that with our brain injured clients, we don't have an evidence of somebody with a spinal cord injury, somebody with an amputation. It's much more difficult for those clients to access some of the benefits because of the hidden disabilities. And again, we see that with the education system, I have brain injured children where we work incredibly hard to get their educational healthcare plans. We get the funding, but then because of both the difficulties that schools are facing in general with their cutbacks, that the actual one-to-one attention that's required for that person is not given. Or I've got a young man at the moment who's been put into a GCSE class when we've said there is absolutely no way that he can absorb that information. They've said, well, there's nothing else we can do. So those the challenges are exactly, my views exactly about as to what Keith has said. I suppose in terms of the opportunities, one thing that we've seen in the last 15 years is the emergence of an absolutely fabulous roadside assistance for people with severe injuries, be that TBI or spinal cord, but in particular with TBIs. With the advent of the air ambulances, we're getting people into hospitals so much quicker. A lot of those people would have died previously. What it does mean is that you're left with some very severe brain injuries. And the difficulty is, although we've done brilliantly in working with the emergency medicine side and the air ambulances and the provision they provide, we then have them in an acute setting. But as Keith said before, when we then try and put those people back together, that's where the difficulty comes. I think another cause for optimism, however, is with organisations like Headway and other brain injury charities, and I suppose in general because of acceptance with neurodiversity, we have got so much more of an acceptance of people who are differently disabled. And if we could only sort of, hinge into that really and make that something even more positive, as we've seen with the Paralympics, etc., with the physical disabilities, I think that's something positive. But sadly, I think there are more challenges at the moment, and that's where our job as professionals, and in my field as a personal injury claimant lawyer, we have to fight very hard to get the funds that our clients require to give them the best outcomes from their injuries.
Thanks very much, Stephanie. Charlotte, now that you're with us, perhaps you could introduce yourself and say a bit about yourself, your organisation, your area of focus, and then move on to talk about your thoughts on challenges and opportunities.
Hello, good morning, Alistair. Good morning, everybody. So my name's Charlotte. I am a complex care nurse working for a company called Alcedo Care. So we provide complex care to patients out in the community. We do have a wide range of focuses, including acquired brain injuries, spinal cord injuries, and lots of other different conditions. We, as a complex care provider, have a team of registered nurses. We have a team of mental health nurses. And we start right from the basics of getting to meet our patients, incorporating a tailored person-centred care plan for each one of our individual patients, and working with not only the patient but their families What we do then is incorporate a wide range of training that's very specific to each individual client. We have actually won awards for our training, which is brilliant. In 2024, we won the Princess Royal Training Award, which was a recognition of how thorough our training capabilities were. So we really pride ourselves in delivering fantastic training to all of the staff that we have, who are out on the front line caring for patients and their families as well. So often, again, if I'm being really honest, a lot of our problems are what you guys have already said. So the main concern for us is funding. But when it comes to funding, often what we do find is it may be highlighted about some certain aspects of care that's required, but actually some of the invisible aspects of care go unnoted. So in relation to maybe people who are suffering from social vulnerability, isolation, emotional problems such as depression and anxiety, who often when we come in and provide these care plans, it's not always everything's been identified from the start. And I find that as nurses, when we are trying to liaise with the MDT and liaise with the patients, we do often find that there's actually much more complexities than was once informed to us. So we find that there's much more need and requirement for actually additional funding. So trying to get that additional funding on top of the funding that we're already trying so hard to achieve can sometimes be quite difficult. But it's very essential. Each one of our patients we do advocate for. So what we do is we've got a really good direct link with the MDTs. We work and have a close relationship with them to be able to get them on board and get them on our side, to be able to advocate them for the patient to try and achieve that funding for those individual patients.
Thanks, Charlotte. Any thoughts on challenges and opportunities more generally?
In regards to sort of what I find as one of the nurses frontline with our patients is actually sometimes even just getting the referral for different teams. So maybe if we need some further rehabilitation, when somebody comes out of a rehabilitation centre, we can find that often the wait list is very long, very extensive, and we are having to fill that stopgap at that time to be able to provide that service. When realistically we need more integrated care between us all, and it's the wait lists that are causing a bit of a problem. Luckily, we have got the ability to teach techniques to be able to help our staff, to help the individuals in the interim, but we do find the wait lists have become excessive, even for things like accessing speech and language therapists, physiotherapists, occupational therapists, depending upon who the commissioner is, can alter the time wait as well for those services.
Thanks, Charlotte. That's really helpful. I'm going to open up the discussion now, and we will come on to talking about innovation and new approaches and new developments. But just before we do, and I do promise, Stephanie, if I go around the panel again, I shall do it in reverse order. Does anybody have any thoughts on awareness and communicating the scale of some of the issues involved? Because that seems to sort of link into some of the points made about funding, legislation, having a more integrated approach. Do we think that there is a really clear awareness among legislators, decision makers, and the general public about some of the issues that have been mentioned?
No, I don't think there is, Alistair. And of course, the difference between our, people who are affected by spinal cord or amputee is that they still have a voice. And although, that voice is often really diminished by pain and difficulties, with a lot of our brain injured clients or the people that we meet in everyday life, probably one of the vast things is stroke patients. The stroke patients by themselves are often unable to speak or have real difficulties in that. So you are relying upon people advocating for clients with brain injuries, either traumatic brain injuries or acquired brain injuries. And we do have some sort of excellent organisations, but I think, in terms of the sort of pecking order, we often come fairly low down because it's not quite as sort of, you tend to find again, we're not, you don't tend to have many brain injury people in the Paralympics, etc. It's not something that's, look what I've achieved and how I've moved on. So I think it's even more important that, organisations, be they legal firms, case management, nurses, or organisations that are dealing with people with brain injuries, are as vocal as they can in terms of supporting people with the awareness that's needed for the wider audience, which really is local government, higher government, etc.
Thanks, Stephanie. Keith, I mean, you talked about funding and the ABI bill. From your perspective, a more general awareness of quite how long-term some of these care plans need to be would seem to be an issue.
I think so. The long-term nature of the need and the need for ongoing support, potentially and normally for the rest of somebody's life. I think to throw a significant bomb into the conversation, something that's been around from time to time, but because of what we heard earlier, that it's a bit of a business, it's an industry, doing the thing that would potentially have the best opportunity to offer some solutions is difficult to make happen, which is we need a model whereby funding to support somebody after a brain injury is automatically available depending upon their need, but you don't need to fight a claim to get it. That immediately saves many, many thousands of pounds that go into paying the likes of me and others that do reports and actually run these claims. So we need a fundamental change in the system. Insurers know how many millions they're paying out each year, and they have a system to try and manage that, which is why they resist settlement, and then eventually it comes the turn for that one to be paid out. So if they know what it costs, if all of that money was placed into a fund to actually fund rehabilitation and other relevant monies, and much of it wasn't needed to pay for the likes of me to do medico-legal reports, and sadly for the likes of Stephanie and her bar colleagues to fight claims, but just was there as a National Health Service, then people like Charlotte could get their funding, could not have to go to a big NHS waiting list because there'd be adequate resources. A massive amount of resource that's going into a business and an industry that actually, as much as we all within that feel we're helping, we are part of the problem.
The difficulty is that there is such a lot of administrative bureaucracy within the NHS that what we see. I suspect that whilst I completely endorse what you say, I think the difficulty is that we really need that stream of funding to be very much a joined up thinking. And if it wasn't, because at the moment you have patients, clients who are in acute units waiting then for a rehab bed, and they'll go to a local district general hospital who won't know what to do with them, where then you fall into the category of your neurobehavioural, because then we'll be told, well, actually, this person now needs a tutor-on care regime. And even the neurobehavioural units will say, I'm really sorry, although we're a neurobehavioural unit, we can't take you because we've got too many people who need that support at the moment, and we don't necessarily have the capability. You then get somebody into the rehab unit, and then, as you say, when we're then looking to discharge, be it a compensation claim or when I assist on our pro bono cases with people without a claim, unless you are going to go to a particular nursing care home, You then have to wait 6 weeks often before you'll be assessed by the local authority. And so often people fall through the gaps. They are, unless you have a supportive family, and I think probably everyone around this table would agree, probably the most important factor which will give you hope and positivity for recovery is a supportive family who are there to advocate, be trained up and help you. But if you don't have that, and so many people in this world do not have that, we deal with lots of young men, as you say, Keith, who end up going into prison because they've had a head injury. And they just don't have the support needed. So the difficulty is that in an ideal world, it'd be perfect if we had that stream of funding. But they would have to make sure that we had almost like a neuro navigator. And I don't know whether you have neuro navigators throughout the country. We certainly do in London, the Greater London. But Charlotte, I don't know if you have neuro navigators in your neck of the woods. But they are sort of supposed to be the interface between the patient and the funding.
Thanks, Stephanie. Stephanie, when you're not talking, can you switch your mic off?
Yes, sorry.
Just a little bit of background noise there. That's great. Thank you. Martin, we seem to have sort of moved into, new ideas, new ways of thinking and innovation. You've got a very long-established business. Could you maybe start to sort of tease out some thoughts on innovation, new approaches, and things that will substantially improve brain injury care in the future?
Sure, absolutely, no problem. Interestingly, listening to talking about the NHS needing a service themselves. Originally, when we started, it was just the civil litigation claims that we dealt with. However, 15 years on from there, I originally was in the early days in the role of case manager. Nowadays, as a company, as an organisation, with my background, social work, we are metamorphosizing into a third area, which is the funding area, which people have mentioned this morning, but it's about being able to tap into that area. And I'm using a lot of my social work background to do so. So, for example, direct payments have been mentioned. That's the bread and butter of a social worker. They do that week in, week out. So direct payments is not normally an issue. As an organisation, we undertake benefit reviews, which helps clients either waiting for a claim or without a claim, maximising their monthly income. But then there's all the CHC stuff, so the personal health budget, which you can apply for and hopefully obtain through the NHS. And traditionally, it was a panel that used to sit, and a social worker and a nurse used to visit the panel once a week and try and justify funding based on what the client's needs were at the time. So we have noticed very much a move towards the original and traditional compensation claim, litigation, civil litigation, I beg your pardon. And now we're sort of moving halfway between the two, noticing that there is not really a link between NHS and private. So we're trying to plug that gap and say, look, we will come in originally under the auspice or the umbrella of case manager, but we will be able to provide social work services out there in the community in terms of funding, in terms of accessing care, in terms of accessing treatment, rehabilitation, and it's working very well.
Thanks, Martin. That seems to be a theme that's coming up again and again, the need for a more integrated approach and making accessing services much more simple for the user or for carers or for anybody involved in the rehab community. Charlotte, could you maybe sort of pursue that and talk a little bit about your thoughts on those things that will substantially improve care in the future in terms of innovation, new approaches, new ways of thinking?
Yes, of course. Yeah. So from our perspective, slightly different, I suppose, in respect of being the nurse and going on and working with the patient. From our perspective, we want to try and build relationships and establish that relationship, possibly prior to any healthcare assessments that are completed, just so that we're able to really advocate for that patient, because often some challenges we do find is that when these healthcare assessments are brought up and patients are looking for complex care providers, that relationship is expected to just be rolled out quite immediately without actually getting to know the patient and understand what needs that person actually has, to be able to advocate from a different perspective from them and to be able to then seek that further benefit. So even in relation to things like from the ICB and sort of taking charge of working with the patient for healthcare assessments, which include like your 12 domains, and going through each individual aspect together to try to ensure that things aren't missed out. But also as well, like Stephanie was saying earlier about having that liaison to be able to discuss this with and having more of a pathway. It's something that we do find does happen, but it is a very limited service. And we do feel as a complex care provider that often there's a gap for a role within the NHS of having a liaison to ensure that there's a smooth transition between one party and another, because particularly in the adult services, that transition often isn't smooth, and parties and MDTs, they don't always have the time to be able to liaise with one another. Information sharing between one party and another can be quite difficult to achieve. So having a liaison worker that's able to advocate for the patient and be able to liaise with every individual service to ensure that the person themselves gets the best out of the assessments, the funding, any grants that are available to them, so that they've got that pinpointed person or team of people to be able to support them upon discharge from a facility out in the community. We do know it happens and it is available, but we do feel that more funding could be put into those areas to ensure that there's a real structured plan in place to make sure that that happens.
Thanks, Charlotte. Stephanie, innovation, new approaches, things that move care forward?
Well, I think sort of Charlotte's idea, is excellent. In a way, it's like having a single port of call. Interestingly, we do work at the London Spinal Cord Injury Centre, so we have a lot of spinal cord patients. They have a case manager that sort of looks after them from day one, sorts out their package of care, and kind of brings them back into the spinal cord centres for their reviews. You don't tend to have that with brain injury. So I think sort of when we look at brain injuries, in reality, very little has changed over thousands of years. We're still effectively, somebody has a brain hemorrhage, we're still drilling to release the pressure. We're really using drugs to sort of monitor and deal with them. So the actual medical side hasn't really, there's not a huge amount that's changed. It's not like when we see some of the developments in technology with spinal cord patients, for instance. So I think so much of it comes down to those therapeutic and soft skills in terms of the integrated approach of psychology, speech and language, physio, and an MDT approach. And again, one of the things that we do, because we only deal with catastrophic injury claims. We don't deal with anything else, and so we specialise into that area. That we are literally with our clients. If we're instructed early enough, we'll go and attend the family meetings, the MDTs. We'll be involved. I'm fully integrated with this sort of CHC systems, the risk assessments, the DTEs, etc. But I think the importance is actually spending some time at an early stage with the families as well, because slightly going off the track of the funding, but when we talk about challenges as well, it's often, if you're lucky enough to have a family, sometimes the families themselves can be as challenging because they really don't have the education about what a brain injury involves. And you either meet people who have no hope, and I think if that happens, sometimes it's the medical profession who write people off too early. But on the other hand, you have people who are completely in denial and oblivious about what a brain injury has done to someone. And then by the time they're discharged into a home setting and they realise that this person is either aggressive, disinhibited, ending up sort of being completely inappropriate and getting into difficult situations, and then they can't cope, it's often a little bit late down the line. So I think, again, brain injury education for families and all those, employers, we've got the Equality Act, but when it comes down to it, it requires an advocate to work with employers to get people back into a working environment, be it part-time or full-time. So again, I think it comes down very much to a lot of personal skills, because in terms of actual innovation, I was watching something on one of the breakfast TVs, so something called Clarke, which is all about technology, cyber technology. There is something called the cyberopulum or something, all cyber stuff, but basically there was a man who'd had a brain injury or a neurological disease. He had a cap on his head with lots of things, and he was controlling what he did with a robot by his thought process. So in terms of some of our functional difficulties that some of our clients have, we can see that there is innovation out there, but that's so expensive. That's going to apply to such a small percentage of our clients, although the technology and the assistive technology that goes into that is clearly something that we are very much on board, when people have got speech difficulties, locked-in syndrome, etc. But the reality is we're not talking about sort of medical and technological innovation in terms of with some of the spinal cord stuff where people are regenerating nerves. With brain injury, we are very much looking at a bespoke, people-centred support network, I think. Anyway, what do you think, Keith? You're obviously in that field.
Thanks, Stephanie. And a nice segue for Keith there to come in. You started this sort of discussion, Keith, by flinging what you called a little sort of bomb in terms of thinking about new approaches. Could you maybe say a little bit more about your thoughts on new approaches, innovation, whether that's technology-led or relating to the wider brain injury community, as Stephanie raised?
I think really echoing what Stephanie closed on, what we need to provide for someone with a brain injury is largely human services. They need people specialised and knowledgeable enough to meet a variety of needs that the person has. And I think the difficulty with brain injury, which makes it different to many other conditions within the health service, is that one brain injury brings a variety of problems. And the NHS is organised for each of those problems to have its own separate silo or referral pathway or way of dealing with it. So, if you've got problems with your behaviour, with your mood, there's a mental health pathway. If you've got some physical problems with coordination, spasticity, some other form of disability linked to your brain injury, there'll be an orthopaedic or a disability pathway. If you've got family issues because you're no longer able to fulfill your role that you had previously within your family, as a mother, as a supporter for children, or as a father, as someone bringing in income to support the family, then there's social care and the Department of Work and Pensions and Benefits. So what happens is that this very complicated person needs to go to lots of different places or be supported to do so. And then many of those places will say, oh no, we can't help you because you've got this other problem, you need to go to that other place. And you go to the other place and they'll say, oh no, we can't help you because you've got that other problem. So it is about coordination. It's about brain injury being recognised as a pretty unique disability, acquired problem of its own, because it affects so many different areas of physical health and well-being simultaneously, along with mental health and well-being and cognitive function. And we just don't at the moment have a system that can do that, because to make the current system we have run efficiently and run quickly, we have waiting lists for particular types of care, and we have criteria which allows you to manage your waiting list by saying, oh no, you don't fit us, off you go, and that's somebody off your waiting list. So we really do need to argue for brain injury being seen in some separate form and having a better coordinated service that meets all of those needs simultaneously. It did happen once, mysteriously, for some strange reason, back in the mid to late 1990s in the county of Kent. The Kent Social Services recognised brain injury as a separate disability. So they recognised that, yes, you've got people with learning disability, yes, you've got people with mental health problems, but here's a separate group that we need to provide bespoke services for, people with brain injury. And I suspect that only came about because the chairperson of their local headway was a former Lord Mayor of Tunbridge Wells, an important town in Kent. But it was an amazing thing to see. And we thought that was then going to have a domino effect, but no, it didn't. And then, some years later, it's disappeared as a separate disability within the county of Kent system. But maybe that's something that we do need to think seriously about, the uniqueness of brain injury, its multifaceted needs, and the inadequacy of the current system to meet all of those needs in a coordinated way. And the poor person with brain injury and their family just
I think we've just lost Keith there for a second, and he's frozen. Keith, we just lost you there for a second, but I think you were coming towards the end of your remarks.
So yes, I was just saying that what had happened in Kent with brain injury as a separate disability, the need for that degree of coordination and acceptance of multiple problems in the same person that needs a coordinated management. You can't be bounced around from different service to different service, particularly when many are going to say no. Substance misuse is another key one that we find. For many people that come through to our service with a brain injury, they've also had a history of using substances. So they need substance misuse help. But a substance misuse service will typically say, oh no, we can't help you, you've had a brain injury, and vice versa for the brain injury service. It's very rare to get that coordination where you try to support someone with substance misuse, whilst also understanding they may have memory difficulties, they may have problems in remembering the content of the sessions and putting into practice what they may have agreed with in the session, but then when they're out and about and once again facing the challenge of alcohol or drug availability, they then aren't able to remember or initiate putting that into practice.
Thanks, Keith. Some great examples there. As we draw towards the end of this discussion, I'd like to punctuate it by going round the panel again and asking each of the panelists, were they to pick, let's say, one thing that they think could make a fairly fundamental difference to the positive future of brain injury care as we look forward, what would that one thing be? Keeping in mind, I mean, Keith mentioned the ABI bill. Let's assume that we have legislators listening to this discussion and you have the chance to send them a message about changes that would alter brain injury care in a positive way for the future. I'm going to come to Martin and then to Stephanie, because I did promise I would, and then I'll come to Keith and Charlotte. So, Martin, just to sort of bring the discussion to a close, the big thing that you think would make a positive difference.
Okay, yes, thank you, Alistair. So, I fully agree with what Keith has just said about the issues with services. and the lack thereof, and also earlier on funding was also mentioned, and there is certainly a lack of funding. So the one thing to answer your question, Alistair, which is what we would like to see would improve the service, that we came to the realization a couple of years ago here at Neuro Case Management that we had on the one side, the left hand, the statutory sector. NHS was great. They offered a lot of different services, a lot of different opportunities for rehabilitation, and they were great. And then the right hand, private sector, also offered a lot of really good opportunities, both financial and rehab based and support mechanisms. What we tried to do is we've tried to take a step between the two and to try and help both the statutory and the private sector liaise with each other, coordinate with each other, and for us to access services from both statutory and private. Because as we see things, as of probably 2 years ago, you have great systems in statutory, great systems in private, but the two never speak to each other, never talk to each other, never liaise with each other. As Charlotte said, it would be ideal to have a coordinator in the NHS who could coordinate. We've been doing that nearly almost 2 years now, putting ourselves in the middle of trying to liaise with private and statutory to coordinate services between the two, which has never, ever been done before. And we're getting very, very good results throughout the country.
Great. Thanks for that, Martin.
Okay.
That's excellent. Stephanie.
Well, I think I echo what everybody said before. I think a streamlined brain injury service that's government funded, but alongside that, or incorporated that, I would like to see some form of employment as well for people with brain injuries. Some of you who are old enough to remember the old Remploy days, and I am one of those people, you know, I thought that was a really good service for a lot of people, because we all want to feel valued, to put back into society, and to have structure and routine in our lives. And we can only go so far. But we need to either, a lot of our clients do get back into work because we put a lot of effort with our vocational occupational therapists at getting them into work by having long conversations with employers. But in reality, we should be actually offering some kind of either incentive to employers or some kind of focus that allows people to be in some kind of meaningful employment, and hopefully paid employment, because there just aren't the opportunities. So, you know, that's, I always say if I won the lottery, I would set up a private service that was there to actually provide employment resources and opportunities for some of the people that I've worked with. Because at the end of the day, compensation gives financial security and all sorts of other things which are brilliant. But we all want to live a fulfilled, valued life. And I think, you know, to be able to go back to that kind of routine is what's often missing in people's lives.
Hey, that's a brilliant one, Stephanie. And we'll all keep our fingers crossed for you this weekend if you buy a couple of lottery tickets. Charlotte, can I come to you next? And then I'm going to go to Keith for some final words. Charlotte, one big thing.
Yeah, so for me, it would be promoting awareness of acquired brain injury and recognising that it is a condition that's an umbrella term, containing multiple aspects of health needs, which require a specialised and structured pathway to ensure that each individual affected by acquired brain injury have access to the care and support they need. I think it's widely unrecognised, and I think that we should, as healthcare providers, continue to educate friends, family, anybody that we come across. But I also feel that it should be more of a government structured education to provide this knowledge to everyday people to be able to support and recognise and understand, so that we can work holistically together to provide more effective support so people can live lives that are back to a little bit of normality for them.
Great. Thank you, Charlotte. And Keith, you get the last word.
Thank you. I think we're all very much on the same page around the need for still a great deal of work around people living with brain injury. I think if there was one thing that maybe could be done that could make quite a big difference, it would be treating brain injury a bit like a protected characteristic. And what I mean by that is, if you go to a social service and to them, that they cannot deny you access to that service because you happen to also have a brain injury, that they have to learn how to accommodate your unique needs and maybe adapt their programs, adapt their treatment, adapt their service accordingly. But no more should people with a brain injury have that used against them as a reason why they can't receive a health or social care service. And I think it'd be nice to end on a real positive. So a positive really speaking to Stephanie's description of employment and the need for employment and meaning after brain injury, which is absolutely spot on. I've been really fortunate to see with my colleagues at Headway East Northants, we've had a number of people that join us as clients using the day service because they've had a brain injury and they need to get some social rehabilitation to get back out there. And then they've made further recovery through that, and they've become volunteers. They've then come in to help their peers with activities and sessions. And then some of those volunteers who themselves have had a brain injury have become employees. They've been able to be employed by the day service as facilitators. So a complete journey from brain injury, client, volunteer, employed facilitator for the other people that are coming into the centre with brain injury. So if we can kind of support the third sector that provides these sorts of opportunities, that could grow employment. Because, of course, once you've then been a facilitator at a Headway, you might want to move on to a care service elsewhere. It will get you back into that particular field. And maybe there's other employers that could look at incorporating folks with brain injury. Yeah, I'm old enough, like Stephanie said, to remember Remploy, to remember a whole host of sheltered work opportunities that used to exist, which have fallen foul to our need to tighten our belts again and again and again, and they've been let go, which is really sad, very sad. But I say employment can happen after brain injury, and let's stop using brain injury as a reason to deny people a service that they need.
Thank you for ending this searching discussion on such a positive note, Keith. That was Rehab in 2025 in Pursuit of Progress. On behalf of NR Times, I'd like to thank a fabulous group of panellists, each and every one of you, for sharing your experience and insight. I think we've unearthed a whole series of strands there, which we'll come back to in the future to explore in more detail through NR Times. I hope that there are legislators and decision makers and policy makers watching this, because I think some of the ideas and topics we've covered should be incorporated into wherever the ABI bill goes. Thanks to everybody watching. This discussion deserves to be seen and heard by as many people as possible. So I hope everybody watching will use their social media channels and their networks to make sure many people see this as possible. So thank you for watching. Thanks once again on behalf of NR Times to all of our panelists, and enjoy the rest of your day. Thank you.